Great, thank you. Very excited this morning to welcome two speakers. They're just incredible women, and whatever introduction I write will not be sufficient. But Candace Henley was only 35 when she was diagnosed with colon cancer and intimately knows the struggles of advocating for your own healthcare throughout her journey. In 2010, she founded the Blue Hat Foundation for Colorectal Cancer Awareness, which supports many underserved community members who don't have access to cancer prevention resources. In addition to running this thriving advocacy organization, speaking nationally on cancer prevention, she also serves as a community advisor to several Chicagoland medical systems in order to bring a patient perspective to decisions in healthcare for myriad cancer survivors. Joanne Glenn is no less impressive. She became a registered nurse more than 40 years ago, and she pursued further education because she loved to learn, becoming a paralegal and getting an MBA. And during her PhD coursework, she pivoted to advocacy for women with breast cancer because she felt the need to shift in 2005 and founded Women on Top of Their Game to similarly provide a voice for underserved communities, as she puts it, to work for a healthier tomorrow. She has been involved in numerous patient advocacy projects across Chicagoland, supporting an immeasurable number of breast cancer survivors. And both Candace and Joanne have taken it upon themselves recently to start the Truth Talking Tour to talk about sexuality after cancer, which is a very inspiring event for women who are cancer survivors. And I could go on and on forever and ever about these women, but I'll let them take it away and talk to us today about patient advocacy and the importance of lifting others up. So
thank you so much.
Thank you.
Candace, you want to start with a good morning so you can be safe driving?
I know, right? Good morning, everyone, and thank you so much for joining us and tuning in and listening to my partner in crime that we call partner in colon cancer crime and breast cancer crime, the pink and blue collaboration. We don't take this lightly, and the patient advocacy is such an important piece to the patient journey, but also having someone to fight on your behalf, with the medical system, and to inform the medical system and doctors and providers of the needs of the patients is so important, and can only come from those of us who have walked the walk and talked the talk and advocated and cared for our loved ones and our family members and ourselves. So we hope that the information that we provide today gives you an insight on the need and the importance of patient advocacy, and that if you are a provider, that it may help you understand the patient perspective. And if you're a patient, if you're interested in participating in advocacy, we can talk about various ways of how you can be a patient advocate, and it doesn't require a lot.
Thanks, Brenda. So thank you again for joining us this morning. This is going to be a very open, truthful sharing of information. So put on your tough stuff this morning. Let's get it started. As I started, I have gone back to school. I'm actually getting ready to do my IRB in oral defense. So I have got a chance to go back to school. So I'm finishing up my dissertation in health administration. We have a short, sorry, they haven't had coffee yet, slideshow, which I'm going to go ahead and share the screen and it kind of walk through what we're going to do this morning. Please, this is an open conversation. Any questions, we welcome. Anything that we need to talk about. Hey, screen. Has my screen shared? I just see the hand up. Yes.
yes, I can see your screen.
Okay, great. Thank you. Thank you. So advocacy and quality. This is going to be a candid conversation based on lived experience and the work that we do. So advocacy and quality, as we know, is a work in progress. Let's start this show rolling. Okay. I should have sent you the slideshow. Hold on, please. Stop moving. Candy, give some small talk while I set this up, please. It's not
Okay, definitely. Well, so you know what, advocacy, what I've realized as a patient is that it's not just advocating for the patient, but advocating for the quality of care for the patient, advocating for the quality of life for a patient. And for me, when I got started as a pissed off patient. Let's just be real honest. And that was because I didn't receive the care that after I realized other patients that I connected with that were 35 diagnosed with colon cancer like myself, we were all in search of like.
Are you there, Candace?
Oh, we lost you, Candace.
Okay, so I have the PowerPoint working, looks like now. So I'll go ahead and Candace top in. So again, it's the White Foundation, Women on Top of the Game, and the Blue Hat Foundation. You can find us on the website, and we work with the community organization. And why our work is important? Our work is important because we help support the voice of the patient. When they receive that word cancer, it still takes the breath away. Some of the things that they process don't make sense. They don't know what to say. So we are the one that advocate and navigate their care. So this will be our agenda today. Talk about accountability of the provider and the patient. So it's a dual responsibility. We're going to talk about the visit, tell a few stories, standards of care, and what's important from hearing versus listening, because there's a big difference, and we're going to talk about that. So resources, follow-up, compliance, prevention, progress, and monitor. This would be very important, and we are expecting some exchange dialogue on this because, again, we're going to be very sharing and blunt. So what's a pink and blue collaboration? So as you know, pink recognizes breast cancer and blue is colon cancer. It's also boys and girls, tops and bottoms. So what we do is we make joint visit with the patients. We do a lot of research. We advocate, we go with policy, and we make sure we're on the room, sitting on the boards where the changes happen. It's no, and I was talking, and we had the screen up. No, Candace.
Someone's not muted.
I guess she's talking, we didn't hear. So again, it's time for a significant change. Business as usual and doing the same is just not acceptable. And even in 2022, things are very much the same as they were decades ago. And I say that from experience. As shared, I've been a nurse for over 40 years, doing direct patient care, policy, advocacy, and as we say in the street, making a difference. So the patient should not just be looked at as a diagnosis, but an individual that has different needs, maybe the same diagnosis, but other circumstances that may be factors that you need to consider when providing care. Culture sensitivity for sure, take into back health literacy, resources, social determinants, and what the challenges are. So that's why we exist, to help be that voice for the patient. I want to start with financial toxicities. I have, as a patient advocate, been dealing with financial toxicity versus healthcare for patients in Illinois, Indiana, and St. Louis. And when we talk about financial toxicity, we talk about what's not covered in healthcare, even though that should not be the primary source of care. It is starting to weigh over into care. So what we say to our patients, to say to their provider, if somebody talk about something that's not covered, instead of just saying it's not covered, let's look for resources. So let's look for alternatives. Let's be innovative. And to put it lightly, stay in your lane. You're providing medicine and care, not finance. The finance is the burden of the family, the help of the social worker, and hopefully some charity care and some mercy. I'm going to share
Absolutely.
I'm going to share a personal story that I just went through, what happens to be the Indiana story, and then we'll talk about Illinois and St. Louis in a bit. That happens to be my brother, my baby brother, that is going through esophageal cancer at an Indiana hospital. So he was down to 112 pounds. He lost more than 15% of his body weight from chemo, radiation, esophageal cancer, not being able to swallow. So he was admitted to the hospital because of dehydration, weakness, and everything that comes along right after he finished his cancer bout. He needed TPN, which was offered reluctantly because of insurance coverage. Now, in the hospital, as you know, things are covered more so in the hospital than outpatient. So once he's stabilized, I'll be short about this because this is important when we talk about patient rights. Once he's stabilized and was ready for home, the social worker who the family worked very closely with said, well, we cannot send him home on TPN with lipids, which is what he needs for dehydration, nutrition because of his cancer condition, because it's not covered by his HMO insurance. So the fight, and it was a battle back and forth after 11 days of an inpatient hospitalization, was he's medically stable, so why do we keep him in the hospital? So the nurse and me look at the utilization management. Well, you're going to get dinged because this hospitalization is not medically necessary at this point. He can go home with TPN and lipids at $135 a day versus $2,000+ a day in this hospital bed that somebody else may need, especially since we've observed patients in the ER being treated and not in a bed. So I'd just like to stop for a moment, and I'll tell you a little later how the story went because it didn't end well, about what your thoughts of with financial toxicity. Is it new? Do you work with social workers? Do you disregard it? Or how do you address financial toxicity, which is real in treating patients when you look to insurance cover versus what's not covered? And this is one of the many things that we help navigate with patients. So I'm going to just pause for a moment and see if there are any comments about staying in your lane and how you deal with financial toxicity, please.
You know, and before someone comments, I'll share my journey too about financial toxicity, because it's not always related to hospital, but related to things that are still continuing at home and the inability to continue to maintain employment throughout your cancer journey.
Yeah, thanks for the question, Candace and Joanne. Is definitely an issue, and it doesn't come up enough. It's, I wish, I understand why patients might be hesitant to bring it up, which is, what you guys are providing a platform for patients to discuss this with their healthcare providers. But when it comes up, we get right on it to try to communicate with insurance companies or direct patients to our financial services. We have advisors who are trained and help patients with obtaining Medicaid or coverage that they may need, or charity care, as it were.
So does anybody see this as a barrier?
Yeah.
As far as care planning and making the right decision for your patient in and out of hospital? It's more so out of hospital for visits and follow-up care for home health. Has any of the providers experienced that or are even aware of this?
Mm-hmm.
You know what I think. What I've had and heard and experiences is that medicine has changed, right? And gone are the days of just treating the patient, for what they come in for. The patient is coming in for more than just, or they're coming in with more than just a medical ailment. They're coming in with a medical ailment and other conditions that might hamper their ability to receive and maintain care. And so when you don't treat the whole patient, you miss an opportunity. But also, it's not an opportunity to judge the patient, but it's an opportunity to understand what barriers are you dealing with, because that might be an opportunity. Because if that patient is dealing with a barrier, there may be other patients that were not forthcoming because of embarrassment, or any other reasons that they didn't share that they were having financial issues. And in my case, there in 2003, when I was diagnosed with cancer, there weren't any, and it was in the summer. So there were no resources to pay my mortgage. If you had a home, there were no resources to help you pay your mortgage. You had an apartment, yes, they would help you. So that was one barrier right there. I was, as a homeowner, I was pretty much, and I use this term loosely, but but they weren't, if you can afford a home, then you can, it was, what am I trying to say? Discriminated against, because I had a home. And it was like, we need resources as homeowners too. But if a patient is diagnosed with cancer, there are several barriers. Can they continue their employment? Is there an issue with that? ADA accommodations, those are all huge issues that patients have to deal with. And they have to deal with these issues with their employers, because employers don't always care that you have cancer. They care that you can do the job that you're hired to do. And that's when, as physicians, you can be very helpful in helping someone maintain their employment by providing an opportunity to fill out paperwork for ADA accommodations, for the paperwork for a patient to take off intermittently to receive treatment. This all plays in the toxicity of cancer that I don't think that people really pay attention to. And depending on the type of job that someone has, are they on their feet? Do they sit down all the time? Do they drive a bus, like in my case? What industry are they in? All of these play a role. And then how well are they able to maintain their individual financial status? Can you help them, file for Social Security? Because during the time that they're going through a cancer diagnosis, guess what? Patients can file and receive Social Security disability. And it depends on the level of treatment and the level of depending on the cancer. But stage 4 cancer patients can actually receive disability, Social Security disability faster, just like with Medicaid. So these are tips and tricks that people are not, they don't know about because no one talks about it. But these are things that I discovered along the way. I fumbled through this. And so I'm sharing this so that you can pass this on to your patient base, to your practice, everyone in your practice, so that you are very well able to help the patients that come into your practice.
Thank you, Candace. It's very important addition, because again, the reason why we're sharing some of these lived experience and inside stories, it goes back to compliance. When patients have barriers or other things that's keeping them from their appointments, keeping the hydration and the medication compliance, it's part of the total care holistically of what we're doing with the patient. So again, you may not know this because you have a 15 or 20-minute slot. The patient does not want to talk to you about it. As Candace says, they're embarrassed or they're scared. So these are real things that happen that affect the outcomes of their care. Embarrassment is real. Most people, patients, especially if they're the head of a household, they're proud. They're taking care of their family. So why do they want to come and show yet another weakness when they've already been diagnosed with a cancer diagnosis, which has caused them to change their life and change their condition? So we work with policy, we look for innovation, we listen to patients, and we make sure we can find some resources that work that can work in their area, in their situation, because no two patients are the same. Again, the diagnoses may be the same, but the patients are definitely individuals and should be treated as such.
Absolutely. And the way you treat a patient is important.
Yeah. Not just a quick in and out, 15, 20-minute slot or rounds in the hospital. It's taking time to deal with the whole patient. From not only do you need a prescription refill or is anything different, let's talk about how you're managing with your diagnoses. We have to listen to what patients are saying, hear their story and their needs, and it's very, very important. And just in sake of time, again, the story that I was sharing with my brother, he ended up in the hospital for 11 days. He was discharged after getting TPN with lipid 12 hours for 6 of those days without being monitored, and went into fluid overload. So now comes the kidney doctors, now comes cardiac along with the cancer. So now we've complicated because of financial toxicity and not being able to send you home for $135 a day that the family could, appeal. So now we have other conditions. So he was discharged after 11 days of hospitalization just to go home to call 911 because of the fluid buildup. So another 5 days in the hospital, just recently discharged 48 hours ago with home health care services. That's an Indiana statement. And it's not isolated, it's just fresh. I have a story in St. Louis with a patient that had some complications and had used all of their rehab days. So again, using days, that's money opposed to care, and threatening the family to put him in a long-term care facility, which the family did not want to do because of a bad experience previously. So it's like, well, there are no more days, no more money. What about looking at the patient and what the patient needs, like home health, which I happen to be a co-owner of a home health agency in Chicago for 20 years, but I can share with you providers and docs. So let's you do a home visit like they used to do in the old days. When patients go home, they lose that bell for the nurse to come in. They lose that sheet where the dietary delivers a meal 3 times a day, and therapist comes up. You have to survive at home, and it's a different story. So admission and discharge should be unilateral. Once the patient is admitted, discharge planning should start, and it's not always the story because we have some terrible discharge planning going on, which we're working with. Again, with Paul's, any comments about patient care and financial toxicity before we move on? We really want you to think about it. It's happening more and more.
It is. And I'll tell you, you know what, my discharge planning, the nurse that discharged me, and I had colon cancer. So her parting advice to me was no anal sex. And I found it offensive because how insensitive. But then I was like, are you insinuating that my colon cancer was because I engaged in something? So that's a how to do it wrong. And so when you're discharging in your care plan, be sensitive, be empathetic, but also at the same time, realize that the patients, we're still in that mindset, but also have sensitivity enough to say, is there anything else that you might need at home that we didn't think of before we discharge you? Yeah. Because then that gives the patient an opportunity to disclose that maybe I don't have anyone at home. Maybe I don't have any food at home. I've been here at the hospital, or maybe I don't have the money to cover the prescriptions because, again, I've been here at the hospital. I haven't worked, so I don't have the means necessary to, to get these prescriptions prescriptions refilled or filled. So that's an opportunity, another opportunity to not only just to be sensitive, but also in a way advocate for the patient, because then if the patient disclosed that information, then that's an opportunity for you to say, well, you know what, let's see what resources we have available.
Part of total patient care. Thank you, Candace. So we talk about scope of practice. Things have changed, technology, innovation, COVID, pandemic, how people receive care, how much time is there, the no-shows, the cancellations, and the reason why. So we just want to remind and revisit that everyone, a clinician, has an oath, and we need to make sure that we are considerate, we empathize, and we stay within our scope of practice, opposed to just pushing it off on somebody or not dealing with it because the patient is not speaking out. So again, just putting out scope of practice is important, because when we talk about care, is the care the same for the individual based on their diagnosis of need, or is it based on their insurance or their ethnicity? So please, let's just be mindful that it's important. We have to adjust to change. When we all graduated, however long it was, 2 years, 5 years, 40 years ago, it's not the same. Patients are living longer, conditions are getting more complicated, and the resources are there. You may have to search, you definitely have to be innovative, but we need to find out what works best, as Candace said, for the patient, because what works for patient in bed A may not work for patient in bed B, because the resources may be different. The social determinants are definitely different. And there are a lot of food desert, there are a lot of programs being cut. So what can we do for and with our patient to make sure they have a smooth adjustment, transition to care, and that we help them in their fight for life? Patient monitoring is important. We have to look at their priorities, not our priorities. Make sure that we have intervention, ongoing monitor, and we like to say we like to be proactive instead of reactive. If you've had a patient or incident where something happened, don't wait for it to happen to the next patient. Practice and research. So let's do this proactively opposed to reactive, because sometimes the later you wait, the worse the problem is and the less resources you may have. So please, with your patient monitor, proactive instead of reactive.
Absolutely. And I can say I fell through the cracks. No one monitored me. Had someone monitored me and offered me psychosocial support, I wouldn't have been in a psych ward for 5 days after trying to commit suicide. And the only time someone ever thought to offer me psychosocial support was when they first told me that I had colon cancer and asked if I wanted to speak to someone. And I was still in that fog of, you just told me I had colon cancer. I haven't even processed it yet. But that was the first and last time anyone had ever offered me psychosocial support. And even throughout my visits to the doctors, no one asked any probing questions. How things are going at home? How are you managing with the kids? How's work? And at the time, I didn't think that was something that I should have discussed with the doctor, because I'm like, they're my doctor. They're not my financial resource. But I didn't connect the two. I didn't realize that my physician could have helped me with ADA accommodations with my job. No one spoke to me about that. So these are things that are very important to realize, that you can actually be helpful by patient monitoring, by asking every time there's an appointment, has anything changed from the last time that you were here that we should talk about? How's everything? Are you able to, retain work? And it may seem like that's out of your scope, but that's how your patients remain compliant. But I cannot stress enough how important it is to monitor the psycho support nature of your patient, because that's an ever-changing landscape. I might be okay today, but tomorrow might be a very different thing, because I might think differently tomorrow. So making sure that your patients have the resources for psychosocial support is very important.
And I just want to add, and I keep telling Candace, I'm going to have to help her co-author my dissertation, because my dissertation is on the psychosocial resources affecting the QOL, quality of life. And research shows there's a gap in service and it's not being done enough. So we have work to do in that area. When we talk again about compliance, follow-ups, intervention, prevention, QOL is important by providing psychosocial resources. So that's at the time of admission, the whole assessment process should begin. I'm going to just pause for a minute and see if there are any comments about quality of life and psychosocial, because it's such a big thing in patient maintenance. I'm just wondering how you all are feeling about that part.
No one else has anything to say, I'll say this is a big part of what I do. I feel like sometimes half my visits are like mini therapy sessions, really just trying to support patients, because the cancer diagnosis and having a history of cancer just colors everything, and amps up feelings, emotional distress in any scenario that's going on. And whether it be waiting for your scan to come back, or the death of a loved one, especially the death of a loved one with cancer, and it's a big component.
It is. And so for those of you on the call who may not be as familiar with Joanne and I hate silence. I love engagement. And this is a very important topic. And I realize that you all are listening, but we also want to hear from you. We really want to, because we are true patient advocates. And so we really want to engage with you and know your thoughts. Nothing is too small to comment on, and nothing is too big, because that's the whole purpose of this engagement and this conversation, is so that we can have open communication and dialogue. So I know that you might be peeking in, but we also want you to talk to us too. We want you to probe. We want you to ask questions, because I'm not a silent person. I don't like silence like this. And especially on something for patient advocacy, this is too important to be silent. And I will challenge anyone and everyone, and I push the envelope. If you are not here to learn, then why are you here? But we want you to be here to learn, but we also want you to engage. We need you to engage so that we can work together and so that you can help us and we can help you. Because we can't change the landscape of healthcare if we are not willing to engage and probe the most small things and even to the large thing, because the smaller things are the ones that lead to the large things.
Yep.
So please feel free and chime in.
I'd like to hear from our social workers. Tasha or Zeta, do you have comments on this? And you talk to patients about psychosocial, all these issues a lot of times. So do you have any comments?
Well, this is Ida, and most of the time I'm working with pediatric patients or survivors of childhood cancer. So the pediatric realm is a little more holistic in its approach towards care. So a lot of what I do is to provide financial supports. But I know in the adult world, having done consults, that, hearing your stories, I understand that all of us are lay people, are told to respect the experts, follow through with the experts, which is true when you have a diagnosis and your care in the hospital. But when you return to home, suddenly everything has to be with you and who you designate caregivers, and none of them have the expertise to handle the complexity of care. And I think it's unfortunate that there isn't some sort of supports in the community for families and loved ones that are doing their best. Now, there's palliative care, but that's a whole other topic. But I think we have a real big gap in delivery of care when people are returned to home, because it's overwhelming. What is expected of families, that the first thing they'll tell you is, I didn't go to nursing school and I'm doing a lot of nursing. So that's my 2 cents. I'm sorry to take up so much time, but I hear the frustration and it is real.
Yeah, and your 2 cents is more valuable than anything. We thank you for that, because
Yes.
when you talk about quality of life, our quality life, your neighbor's quality life, your peer and cohort quality of life, or the person we're taking care of, can and usually is very much different when you measure quality, beliefs, values, experiences. So when you talk about QOL, it's very personal. So we have to just remember to be respectful and find out everybody doesn't have the same thing. Everybody does not want the same thing. So it's important as a team, interdisciplinary team, that we work for the good of the patient and try to get the best for them.
Absolutely. And the caregivers, right? Because as you just mentioned, someone said that they were, they didn't go to nursing school. Absolutely. It's stressful on the caregivers because they're standing by the wayside, and they're powerless to help us to get better, right? And so they're doing things they never thought they would do. They're changing bandages, they're cleaning puke, they're cleaning us, they're all of these things that they're like, now they're thrust into suddenly. So that so the care for the caregiver is just important as the patient, because they're overwhelmed, they're stressed, and they're like, I don't have the power. And especially when it's our loved one, our parents and our spouses and our children, they don't have the power. And it's hard for them to see us in this vulnerable state and not be able to do anything better than changing our bandages. But they don't realize that just you being here is more than anything that we could ever ask for.
Yeah, I agree. I think caregiving by loved ones is done from the heart, and there's no better quality than that. But to be in a crisis and to have to learn how to do that, at warp speed is stressful and difficult, and wears down the confidence of the people trying their best to support a person going through a cancer diagnosis. So, we've got some aspects here. Once the patients leave the hospital, that, you know, the support systems are too thin. You know, I don't know how we, you know, I don't know if it's policy or what can make a change there.
You bring up a great point, and I think one of the things that I participate in is the discharge planning with the family. Before you send them home, the social worker comes the day before, 2 days before, to say, well, we're sending you home. Do you live alone? Is it safe in your home? Is it in the food desert? Just to do a total assessment and to include who will be taking care of you. What's the best time they can come in so we can discuss care planning? It has to be a bi-directional communication because, no, I don't have that. Oh, no, I have stairs. No, once I'm up, I'm up. So all of those, again, if the food is downstairs in the refrigerator and my bed is upstairs, you wonder why I'm dehydrated. You wonder why, it's a mess there. So the barriers is part of the wellness. And we have to realize, again, discharge planning, caregiving support, and talking to the patient respectfully at the level of understanding is part of the recovery.
Right.
Definitely.
Good point. Good point. Tasha, I saw you unmuting. Did you have something you wanted to add?
Yeah, I really appreciate the the conversation here, and my where I kind of latched onto is a little bit of a different topic than what we're talking about right now, but I really appreciated the point about engaging in that psychosocial support throughout the continuum of care, and appreciate the honesty and the openness about your experiences. I know that I work in the adult with the adult population, and I do try to make contact when people first come in. I try to follow up for distress assessment, but then after that, just with the volume of patients, it's difficult for me to keep in touch with every single patient. And so I think it's very important for the doctors to be checking in, even a simple, question each time they come in. How are things going? Do you need any additional support? Just as sort of the routine questions can be really helpful to flag, hey, we need social work here, because there are a lot of times that I will come across a chart and it'll say like, patient hasn't come in for the last 3 visits because of transportation issues, but nobody told me that that was happening. Or patient reports, not having food, but then that needs to trigger social work being consulted. And I feel like that part doesn't always happen, that we might have that information, but it's not always communicated to the people who can help do something about it.
That's a good point too. I wonder, does Kate, Kristen, Megan, or Nasima navigation and patient care from a nursing perspective, do you guys have any input on that? How do you interact with patients? Kate, Kirsten, Megan, Nasima. There are navigators and nurses.
So actually, we're trying to start this new process in referring our patients to Patient Advocate Foundation to, so in my workflow, I'm starting to do a social determinants of health screening for all of our patients that come on site to learn more about not just what's going on with their physical and mental health, well, that's included in it, but also what's going on in their life. If they're able to afford food, if they're able to afford their housing, how many times have they moved within the year? If they're everything is being asked in the social determinants of health right now. So we're working right now with Yami on this project to pinpoint all that, and then making sure once we find out that they do need the help, reaching out to the resources that they need to assist with them. So that's something actually new that we started actually this week. We just had conversations about that, like just this week, about all of that.
That's great. So let me give you a little insight on referring to resources. When I was in the midst of everything, every piece of information that was given to me, the information was a dead end. So that ultimately led to me being distressed. When you're in the midst of treatment and going through everything that you're going through, the last thing you need is another resource list, another phone number. What would have helped me greatly if someone had done a soft handoff, called, found out who I needed to talk to, and made that person aware that you are going to give me the information so that I know I had a direct contact to reach out to that person. So now, instead of me just calling and doing a cold call, so I'm trying to find out what resources you have, and someone saying, well, what resources do you know? Because you have to realize that some of these gatekeepers, they're not as friendly. They're not as helpful. So having someone to do a soft handoff for a patient to call someone that they can talk to directly, that's the best way to do that, because the last thing you need to do is give me another phone number so that I got to sit on the phone and wait. And then maybe the person that I call may be available, or that person may not be. Maybe the services may be available, or maybe the service may not be. So thinking about what this looks like for the patient is extremely important.
And again, to your point, Candace, it's service area. Oh, we don't service that zip code. Well, that person's no longer here. So again, that soft handout can make the difference. It's like, well, I forget it. I won't call anybody. It's like, no, you need them, and you need the assistant. So it's really important when you talk about
Absolutely.
resources and handouts.
Absolutely. And it was a deterrent. It was the last straw. And it was like there was nothing else left for me. And I was in distress, and no one realized that I was in distress. They were like, well, I mean, that's all we have. So that's, and again, the way you interact with a patient can make or break that person. So being conscious of, if you're having a bad day, decompress before you engage with a patient, because that patient is you're dealing with something. But if you're going through a cancer journey, that's something totally different. And your interaction could make or break that patient that day. You have no idea how you could say something that could be the defining factor on whether or not today I think I can make it, or today I think I'm going to end it.
Just to jump back a little bit on the idea of a soft handoff, you know, I've been in this field for a long time, and old school was that we would contact the referrals, the people that we were making referral source for, make sure the services were there, name of a person and a phone number, and then hand it off to the patient to follow through. Nowadays, the minute they hear you're the social worker, they stop the conversation. They're like, we only talk directly to the person seeking services. They won't confirm that they have services. So it's a little bit different climate. Yes, that would be really good for you to be able to just have one number and a person to call, but it's not set up like that any longer. That's why the idea of trying to build up caregiving around a person that's going through a cancer treatment is something a little more doable. So I don't know, think about how that can be built up a little bit as social workers make their assessment before discharge planning.
You bring up a good,
You know what?
You bring up a good point, because again, recently when I was part of the discharge planning for my brother, a social worker came in and a case manager. So it was like, so my brother said, who are you and what are you for and what do you do? Do you work together? Your good news, your bad news? So confusing the patient as to why do I need a social worker and a case manager. You have to look at the healthcare system, what works for the patient, and don't just drop the ball, because that's what's happening. The ball is bouncing and the patient is being left out. Again,
Absolutely.
QOL is being affected. They end up back in the hospital. They're more compliant. They miss more visits. And it's just a mad circle, and we have to stop it.
Absolutely. And I always challenge, when I get pushback as a patient advocate, I always challenge you, where does your policy say that you can't speak to me? Because if there's a policy that you have in place that says that you cannot speak to me, send it to me so that I can read it. Because the patient, I am talking to you because the patient knows that and they have asked me to do it. I also get authorization from the patient to speak on their behalf. So I'm one that I always challenges the process when they tell me, well, we'd rather speak to the patient. Well, the patient right now cannot speak to you because they're ill. And so what we want to do is make sure that whatever information that we can get, that we pass along to patients, that they make sure that they have a very easy way of communicating, and that they're not giving any more added stress because you won't give information. And then if they continue to push back, then I ask for the director. Because at some point, well, again, we're advocating for the patient. And so when we allow those that are gatekeepers to keep us from doing our job, then we're not doing our job.
And at the White Foundation, we address breast cancer survivors, and they've coined themselves as butterflies because of the different stages they go through, from diagnosis to treatment to ball, bold, and beautiful. And most of them, of course, are women, and they're head of the household. So again, they've been stricken of their power, of teaching the kids, taking the kids to school, being the supportive one and fun, and all of a sudden they're drained. So what are the resources? So to go to a visit with a patient, which I've done, I hear often, they didn't ask me that before. It wasn't the same. It's different because you're here. It should be the same each and every time for each patient, individualizing what their needs are, but not shortcutting because it's not a professional in the room, another clinician that's being their voice and their ear. So again, we have to be cognitive of the patient we're taking care of, what their needs are, and maybe just reflect that someone you care about and what's the best care for them. Patients have rights. We all know that. They should have sufficient time for the visit in order to give the care. Again, of course, not only do you need medication, a prescription, are you taking your medication? Are there any side effects? Are you able to eat? Do you have diarrhea? All of that opposed to here's another prescription. It's like, I still have some left. Well, you shouldn't. It was a 30-day count. Well, I haven't been taking them. Well, why? Well, I'm about to run out and I have a copay, so I'm stretching the medication. So all of this is part of the visit, part of the conversation, even if it's a telehealth or after the fact. Find out what the patient needs are. Discuss compliance, wellness, and what can we do to keep them out of the ER, keep them from a readmission, and keep them healthy towards the goal of survivorship.
Absolutely. And I think it's also a good practice. It is, and especially when you're talking to patients of other cultures, to ask them to repeat what they heard you say. Mm-hmm. Because so often, patients, we might think that we're speaking, but people receive information differently. So just to be sure that you're understood, can you repeat what you heard me say? And then also be aware of other what cultural differences might be at play that might hamper care. There are certain cultures where there has to be a man involved in order for a patient, a woman, to receive certain type of treatments. So these are things to be very aware of, so that you're not shocked, later on when you go, oh my God, I didn't know that. So these are things, just knowing who your patient is and knowing, not just the barriers to their care, but what are the cultural barriers? What are the religious barriers? These all play a part.
Yeah. Now, who to call and when to call? Does the patient have a working number? Is it just to a service? Is it your cell number? Is it the best number? Do they know when you're available? So when patients are in crises, or when patients remember, I forgot to ask, or I need this, or I got to wait 6 weeks, I got to wait 2 weeks. We need to be proactive and facilitate information that the patient wants, because how frustrated are we when we're trying to get through to somebody that we need and you can't get through and they're off or they're not available, or it's the wrong hours. When you think about the fight of a patient trying to survive and they remember after the visit, they still need their resources. So please, when you give out information, make sure it's current information, not just a voicemail or a message. Or if you know it's going to be a voicemail, share that with your patient. When you call this number, you may get a voicemail, but I check and retrieve my voicemail. So you're not explaining to your patient, you're involving your patient, because again, this should be bi-directional with the care, and it's part of it.
Thanks, Joanne. This is Alon. So, and you and Candace bring up just amazing points. And, part of it is, how are we training the next generation? How are we training residents and fellows coming out of the programs for, how to sit and speak to a patient, how to listen to a patient, how to hear and see a patient. Have you been able to make any inroads in the education training, one of the next generation, two of providers? Have you had an opportunity to perhaps meet with some of the UI Health leadership in a roundtable discussion to discuss some of these issues and barriers? Because this
Not as of
has to
yet.
be
And
discussed.
yeah, not as of yet, and we are waiting for the opportunity because we know from lived experience, from research, again, we're talking about QOL and psychosocial, and things have changed. And as we look back at the thing that the patient experienced, so it would be a great opportunity. So please, we're available and open and willing. So absolutely.
Absolutely.
Good.
Absolutely. And just one other tidbit too, before it leaves my mind, I'm sorry. I hear all the time about patients saying that their doctor says that they don't believe in pain medicine. You're not the one that's in pain.
Right.
So your beliefs, your personal beliefs as a physician should never impact the care that you give to the patient. You're not in pain, the patient is in pain. So whether you believe in pain medicine or not, you're not treating yourself. So that, and that is so inhumane to allow someone to maintain some type of pain. Pain is no joke. So just think about that. Your personal belief should never impede your treatment of the patient.
Agree. And then, so another question, when doctors come into the room, and so they're on a quote, a clock, right? So how many patients do I have scheduled? You know, in a morning session, I have 20. So which means I can spend literally 5 to 10 minutes with each patient, or the provider is under, you know, an insurance contract. And so they're limited to 15 minutes or 10 minutes per patient. Do you think that there's something that we can do, you know, at the state level, CMS, in order to change that psyche, particularly with patients, you know, at high risk, patients, you know, who have chronic conditions, cancer survivorship? Do you think that there's a carve out or a policy that we could impact to allow the doctors, you know, who are told, you know, you're under contract, this is the amount of time that you can spend?
The answer is yes, and I'm so
Yes.
glad you bring this up at this time because I am part of a national Black Nurses Association. So it's a couple 100,000 of us throughout the U.S. that face the same programs and problems, concerns nationally. And as we talk about financial toxicity, the convention is going on now, but I have an appointment with the president on the 5th or 6th of the National Black Nurses Association, and we are looking at policy changes as financial toxicity. And now we're going to add the time allotted because it's a very important factor. So thank you for bringing it up because yes, the power of those to take care of and the voices of, we can make a difference.
Absolutely. And with that being said, it's like when the insurance companies are making the decisions about the type of care that we receive, but we're paying this premium, but you're saying we can only get 15 minutes for $200 and something every paycheck. So I'm not even getting the amount of money, the type of quality of care for the amount of money that I'm spending.
Yep.
And when we're allowing insurance companies to dictate the type of care we receive and to dictate to the physicians that you can only spend this amount of time, that is not quality care. That is reducing the quality of care we receive, and everyone deserves quality and quantity of care. So yes.
Yeah, we're going to definitely put that on the agenda, but here's another kind of a flashback. Look at pharmaceutical. And the fight and the changes that are coming out. It took a while, it's taken a while, but change is coming when you look at what's happening with cost of pharmacy. So again, I think just not doing business as usual and status quo makes a difference, which is why we have organizations and advocacy groups that help change policies. So again, we definitely would push this because you're absolutely right. When I went to one of the many appointments as a navigator for a patient and an advocate, we sat in that room for about 20 minutes in the cold room after waiting in the waiting room for a half an hour with the scheduled appointment because the physician was running behind appropriately. But the thing is, no one ever came in to say, we're running behind. And as soon as we get a chance, you know, the option, did you want to wait back in the waiting room? But letting somebody know you're not just left in the cold room because your time is up. So again, communication, scheduling, all becomes part of that continuum of care.
And
got work to do.
Joanne, if anything that we can do to help advance policy with the National Black Nurses Association, happy to do that.
Oh,
We're here
thank
for
you
you.
so much. Thank you so much. That'd be great. It's a big, powerful group and it's national. So
Sure.
the answer is yes.
Thank you. Thank you so much. You're amazing.
Yeah.
You and Candace are just amazing.
I know this talk is amazing and very rich, and Zeta commented on that, and Betty and everyone in this room like just thinks it's a wonderful talk and wonderful topics, and I want to keep continuing going on, but I also want to give it out for people if they would need to leave at 10 o'clock. But happy to, continue this discussion for a while longer. I'm sure we need this talk every month, every week, right? And we need to, I think, to your point, educating the new generation of caretakers, bringing this talk into fellowship, into residency, even into med school to prepare new doctors for being able to address patients appropriately and to comprehensively care for their patients is important, because this didn't exist when I went to med school.
Well, there's no time like the present, right?
I
Things
know.
have changed. Things have changed. People are living longer and the needs should fit that. So again, being respectful of time, we thank you for your attention, your input. Again, we're sharing live stories, experiences, and making it better for the patient and the family. So are there any last minute questions or concerns? We hope to get back with you and we hope to hear from you.
Yeah,
to address them.
I hope, I want to have you back, every year talk to us in the series. It'd be great. And we'll try to put you in connection with all of our, education at UIC, of course. And, I know you're already on the community advisory board at UIC. Candace is advising on the new cancer center at University of Chicago, and you've been involved at Northwestern. So that everything that we can do to continue spreading this amazingly important word is what we should do.
Well, thank you. The good thing is we're not silent about it. We're talking about it. So thank you so very much.
Yes.
Absolutely.
Thank you so much, Candace and Joanne. I knew this would be an amazing discussion. I had no doubts at all.
Have a great day.
Thank you.
too, everyone.
Have a great day. Thank you for your time.
Thank you, everyone.
All right. Bye now.
Bye-bye.
Bye.